Patient is going to lay on their side. Now, there is an angulation for your lateral. It is going to be 5 degrees toward the patient's head. Okay? That is standard. 5, so I've already angled it already, 5 degrees. A little too long. Come back a little bit. All right. Won't go any further. Slide back. All right, go ahead and lay on your left side, please, ma'am. Thank you very much. Okay, now we got 1 or 2 options we can do with the leg. Option 1, we can have this leg up like that. Or option 2, bring that leg, cross it over. All right, you need to do whichever one is going to probably feel best to your patient. Which one's best for you?
This one's fine. And also, 9 times out of 10 out in clinic, this is going to be comfortable for almost all your patients.
Yeah.
Because not everyone's going to be flexible enough to do this to where you get the knee flat enough.
Okay.
Because if you need to get the knee flat, they might rotate their leg in like this. So 9 times out of 10, your patients doing this is.
So what did you just say, just roll over onto your side?
Roll to your side.
Okay.
Okay. Now at this point, excuse me, sir. Let's put a little something right here to give you a little comfort. How's that, ma'am?
Wonderful.
Okay. All right. So now, once the patient's on their side, we are shooting medial to lateral. Once again, medial to lateral. Okay. So now, according to your paper, where's central ray gonna go?
Directed to the knee and 1 inch distal to the medial epicondyle.
Okay, so we're gonna find that epicondyle. There it is, right there. 1 inch distal. Now, what does the word distal mean?
Away
from the
Okay.
farthest away.
All right, so
From the
1
attachment.
inch. So right there, just going distal kind of means just down. About right there is where I need to be. Boom. That's all we're doing. Now,
Would we bring the collimation in or no?
why?
Because we're focusing on the knee only?
This is the knee.
Yeah.
We don't want to get the.
Just checking.
the back close to you, so we don't want to get it.
Correct. So leave it just like this.
Okay.
Now, what's going on here?
Slight flexation.
Okay.
20 to 30.
All right, 20 to 30 degrees. Okay, no more than that. So, all right, flex your knee 45 for me. Okay,
Too much.
that's almost 90. But come on, more. Yeah, so about right there is actually what we need to do. That's realistic. This is it.
And how would you adjust
like
to make it?
so-
Oh,
so-
does that need to be matched with the leg? Or
No,
The apex.
leave the light feel the way it is. Don't mess with any of that.
Okay.
Only thing we're doing is just flexing this. Okay, so in here, you have a tendon around here. Well, the more you flex this knee, you're gonna make that kneecap get closer and closer to that femur. So you flex it just a little bit, because right now you wanna be able to see this bone, that bone, and this bone. Now, even though there are 4 bones in this general area, only 3 make up the knee. The fibula, the bone on this side, it is not part of the knee joint. Tibia is, patella, and femur. Okay. So by doing this, you're able to see it. Now, the condyles are those 2 big knot bones on the femur. The objective is when you angle this thing, you're able to see these 2 things side by side. Reason being, because when a person stands, one is slightly lower than the other. That's why we gotta come in and we gotta angle. Now, one of the problem with the lateral knee, now the picture y'all got is a very nice picture here, but Ari, roll down some. All right, if I roll her leg like this, I have now taken the condyle on the medial side and moved it forward. And the one on the other side, I've moved it back. And by doing that, we call that rotation, over and under rotation. And it's not, normally they should sit side by side, you can't see, but if you do like this, now you can see one and the other. That's not a good thing. You want them to be superimposed, how they are in that picture, because you can't, they're overlapping each other.
Okay.
Okay, right here. But if she's rotated improperly, one's gonna move forward, one's gonna move backwards. Okay, that's a huge issue when it comes to shooting knees. The patient either rotated too far forward, okay, go relax, now roll back that way, or they'll roll too far back.
And you're just kind of feeling them both at the same time?
Well, normally I can feel hers because my hand can fit. Now you met somebody who got a knee about like this big. I'm not gonna be able to do that. A lot of the time, I got an eyeball.
And the feet don't have to be dorsal flex or anything?
No. So I'm gonna take this with you just for a second. All right, roll down, roll down. Now some patient, being needs a little bit more. Some folks have an issue where they do like this, and you gotta prop something underneath their foot.
Okay.
Okay. And that's because by doing that, you'll see this thing kind of, you'll see it change. Because some folks, their knee, how their knees are, is kind of weird.
Yeah, and like some people, they'll have their heel resting on the
Yep.
table. That will also affect how the knee is rotated. So like my heel's down now,
That rolls it out.
so it rolls it that way. But with my heel up,
Yep.
then it rotates it back.
Okay.
Okay.
So do you want us to rotate it forward like that, or is that too much?
Okay. It needs to be straight, and it's gonna be kind of so like.
It's gonna be like every patient's different kind of thing?
Yeah, because like right now, think of it like this. The condyle should be perpendicular to the table.
Yes.
So really they should be like this. So come on over here, I want you to feel. All right, so put your hand on both. Now, all right, I'm gonna have her, okay, roll your knee. That we don't want.
Okay.
Go the other way. That we don't want.
Okay.
That's what we want.